So, welcome to NUR203 Pediatric Nursing. I am Professor Bogart. As you all know, I do live down here in South Florida. I live in Waterstone. Um, I did start teaching full-time the didactic course at Cutler Bay. It was my first teaching job, and I'm still here. I'm enjoying it. So I went in to teach pediatrics, which I've got a long history teaching and working for Nicholas Children's Hospital. I worked in the newborn ICU. My favorite is the cardiac ICU. And then the last 10 years, it was in the emergency room. And I'm a trauma junkie. So I'm one of those crazy people who like to go around in a bunch of craziness, and I'm the one who keeps the calm. And I've enjoyed it a lot. Now, when I came in to teach pediatrics, they say, well, you got to teach pharmacology too. Can you do that? And I went, oh, I guess I can fake it. Well, little did I know, pharmacology is pretty hard. So I had to relearn it and make it understandable for students. And in that process, I had to learn how to do dosage calc again. But I made it simple. I didn't like the way it was explained. It didn't make sense to me, and I'm very logical. So the way I do dosage calc, I'll show you how to pick the numbers out and what to do for them. So it makes it a little bit easier for you to wrap your mind around it. It's very simple if you think. And actually, I like numbers, so it works for me. And I can teach those students who hate math. So if you have an issue with dosage calc, I'll say it again, make an appointment to see me. It could be when you can, morning, noon, after night. It's up to you. I don't need a lot of time. And I'm going to give you all the information you need to either study at home or study with me. All right. Or do both. So I don't want you giving up any of those 10 points on your exams. The quizzes do not have any dosage calc on it. All right. It's one of the things students do work about. They're like, oh, don't want to give the points up. No, they're not on the quizzes. And actually, I do make all the quizzes, and every quarter is a new quiz. So quiz one is already made. It's ready to go for next week. I have been a nurse for, I don't even know how long anymore, 45, 6, 7 years, a long time. I have worked the adult world, the adult ICUs, adult ER, adult floors, management, assistant director of nursing, supervisor, head nurse, name it, anywhere, I've done it. The only thing I've never worked is OB. Never cared to, never wanted to, just let me catch that baby when it comes out, and I'll do everything that you want with it. So that's my background. So I'm all over the place. What that does for you, it helps you when we're talking about peds and adults and the differences, because I know them. I've worked it. So I can help your mind wrap around what are my differences? What do I need to look for? Because I know what adults are and what children are. Now, my goal for you this semester is everybody to get out and do well. I can tell you last quarter, everybody passed. And why did they pass? It's because when you are not doing well, don't understand, you come back. You want to know the quiz. You want to know what you got wrong, and you meet with me. And then you get an exam and you're, not really sure on some concepts. You meet with me before. You meet me with after. Look at what the questions you got wrong. You are given every tool you need to get an A in this course, but it takes time. I have PowerPoints that I work on every quarter that are there that have every information on quiz, exams, HESI, and I know they're in the NCLEX too. So you've got information. And then I give you an immediate quick quiz by doing Kahoots. Now, these Kahoots, I make the questions up. They're from nowhere. They're not in a bank anywhere. I go and look at the concepts on quizzes, exams, and your HESI, and I make questions that I think maybe is what they're looking for. Now, I've been very lucky. The students tell me it actually is pretty close to what we're looking for on the HESI or on your exams. And I've been told that they hear my voice as they're taking an exam when they're reading a question. Oh, this is what she said. And I'm like, please, no nightmares from listening to my voice so much. Now, I also have a YouTube channel. It's there on YouTube. Is Professor Bogart, Pediatric Nursing, and every single recording from when I started, which is a year ago in January, all the recordings are there. All the exam reviews, the dosage calc in every class. So if you want to go back and look at them and re-listen to them, they are there. They're not like the type Zoom will, after a certain amount of days, will disappear. They'll be not available anymore. But in the YouTube channel, they are. So you have the information there for you. Now, I try to keep you organized. Now, many courses send 100 announcements every week. I do not do that because you're not going to read them, and I'm aware. So I will send you 2 minimum. One's going to be week 1 information. And then after class, you're going to get a week 1 recording, and that will be the recording, the Kahoot link to get there. And I will also post any information like the PowerPoint or anything else again, so it's in one place. I do the same thing for exam reviews. You'll have one announcement where I'll keep updating it with when I get every professor's review, one place. I'll put all your Kahoots there. I'll put everything you need in one place. So all you have to do is go to one page, and then you got all what you need instead of looking, where is this? I can't find it. Well, it'll be trying to make you life a little bit easier. I know most of you are probably in 3 classes, and this is the first quarter that you're getting that. And community is not easy. Community is difficult, and you need to keep on top of it too. So I try to at least help you to be organized. So how do I teach class? Well, first we're going to any questions, anything you need. And then the next thing we do is we'll do a PowerPoint. Now, at any time in a PowerPoint you're not understanding, stop me. I don't mind. I don't get offended. It doesn't upset me. I want you to ask questions. If you have a question, somebody else probably has the same one, right? So please ask. When we're done with the PowerPoint, we're going to be going to a Kahoots. They're anywhere from 30 up to 60 questions, depending on the subject. Now, week 5 is cardiac respiratory. I think there's 60 Kahoots. I mean, there is a very powerful week. It's a lot of information. A lot of your exam and HESI questions are always cardiac respiratory. That's, the hot and heavy subject they like to talk about. So that one's a little bit more. Now, I have a question for all of you. This is Tuesday night. Class starts at 8 o'clock. You get over at 10:30. Now, you are allowed 10 minutes per hour per a break. Now, I can run straight through and get you out early, or we can stop between the PowerPoint and the Kahoots for 25 minutes and then come back and get out at 10:30. Now, do you want to get out early, or do you want to go through and have a break? I don't mind you getting up, going to the bathroom, getting a drink. I don't mind if you need to eat something. Those things don't bother me. So that is not a deterrent for me. What do you want to do?
I say go early.
Straight through. You can work straight through.
No, I mean, most students do. I don't mind. It doesn't bother me. I could talk forever. Not a problem. All right. So tonight, what are we doing? Well, there's 2 PowerPoints because we're going to talk about the rules and the regs on the online course, and then we're going to do the PowerPoint, and then we're going to be doing the Kahoots to follow. When we're done with the Kahoots, we are done for tonight. We should be done about 10 after, quarter after 10 at the latest. So you will be out early tonight, all right? Because we'll run straight through. Again, if you have to get up and do something, go somewhere quick, I understand. Go for it, but please just come back and try not to miss too much information. But you will be getting your recording tonight. So in case there's something you missed, you want to go back, refresh, you'll have it as quick as it can come up and show me the recording's ready, okay? So let's go ahead and start. The first thing you should know about me is you please, anything's going on with you, interfering, you're not getting your work done, please communicate with me before anything is due. I will work with you. It's when you wait till after, I can't. So before something's happening, you have surgery planned, or you come home and your child's sick, you have to run to the ER, or whatever that is. Let me know before class. Let me know before exams, quizzes, or anything, okay? So online is just like on ground. It's just I'm not there in the building with you. And I'm going to be, giving you all the information you do need. So, in case of any problem, you need to contact your instructor. And then they say it's the lead instructor. Well, I'm the pediatric lead instructor. And then if there's something that's so urgent, you need something right away, or you don't understand, or you're not happy, or you're happy, whatever it is, please contact Dr. Brown. I don't get offended, and I'm not going to take it out on you because you went to my boss. My goal here is to help you succeed and be the best you can be in pediatrics. And if there's something I'm not doing or you need an answer right away, please call, text, whatever, Dr. Brown. And here's her phone number right now. So the 720-665-6101, call her. She answers really quick, if not immediately. Also, that's her email, and it's not D Brown, it's her whole name. Apparently, in Fortis, there's another D Brown around. So, anything, please contact me. You can contact me in Canvas with a message. You can send me an email. I have a phone, please, if you need to. I give you my real cell phone. And if something's going on and you need to talk to me right away, text me. And my phone number is 305-951-8055. And it's there in the announcement about who's your instructor, the welcome, okay? So if you need anything, it's there. Don't abuse it. It's not there after 8, 9 o'clock at night. And 6 o'clock in the morning, I'm not going to answer. But normal hours, I'm available. I answer messages up till right before I go to sleep, because it's on the phone. It's really easy today. You can just go and look at the emails, see if anybody needs something urgently. And I do answer, okay? Just make sure that every time you come to class, you are professional. Wear something, not jammies, okay? But wear something comfortable, that's professional. And just, as we're talking, just be the professional person that you as RN is going to be. And that's what it says there. Be considerate of other people. Now, discussion boards, you have one that's due this week. Be careful. It's not only tell me who you are, there's a question about children and nutrition. So it's the first question on it. Make sure if you've already done the discussion question, started it, just go back and add on another portion to it. It's okay. Another question I get about these discussion questions is, can you do answer it and also do the replies on the same day? It doesn't bother me. It's okay. If you have somebody you can answer that you feel that's given you what you need, it's fine. There are some professors who don't like that. They want you to give the first discussion, tell me about the topic, make sure your references are there, and you do your citations. And I will send little messages in the comment box for you, so you'll know why didn't you get the perfect 20 points. You missed, maybe a citation or whatever. I'll let you know. I also give you a little more information on the topic every single discussion question. So as you can see, I do read these things. So see, try to do your best at them. And if you need help with anything with APA, please just let me know. I do usually on either Saturday or Sunday afternoon, I'll send you a message. Hey, you forgot your discussion question. Or, oh, you didn't get your NCLEX in. Make sure you get them in. So I'll give you a reminder, right at the end of the week to let you know. I'm pretty good with that. Now, if you can't get stuff in on time and you haven't called me, so it should be on time because I don't know a reason. And you have one more week to give it to me, and it is a minus 10% deduction. Now, what say you called me? My kid's been sick all weekend, and I'm sick. My husband's sick. Whatever. I you can't get it in. I won't give you a deduction, but you have to let me know before it is due. Can I stress that? Before it's due. I'll work with you. I'm not here just to take points off. I don't want to, but if you don't tell me before, that's what I have to do. With attendance, make sure you're not in a car, whether you're driving or a passenger. Even passengers can distract the driver, and it's all about safety. As I was saying earlier, make sure the camera's on, not at the ceiling. Make sure that you are professional at all times. Now, one of the things with attendance that is really sort of misunderstood is it's not only coming to class and getting the attendance from being here. It also has to do with posting on your Canvas. Now, you need 2 points of entry. So this week will be number one, you post the first discussion question. And then the second one is your peer responses. That's two. But you also have the quiz and whatnot you had to do in order, to start the program, the Canvas shell. So make sure some of you like to work early. There are some areas you can. CJ Sims, you cannot. You can NCLEX questions, you can, and your NCLEX questions and discussion questions, you can work ahead. But be careful. 2 points of entry every single week. And if you don't have that 2 weeks in a row, they can drop you without even telling you. And that's part of attendance. So that's with any online. So be careful with that. Remember, attendance is in the beginning. Remember, 1 minute is 15 minutes late. If you are here, make sure that you try to get here on time. If you're being late, let me know. Now, if you have something going on and you have to be out for the entire class, let me know. What is the reason? And I can tell you how close to 20% you are and how you can get documentation in order to justify why you aren't here. Because if you justify it, doctor's notes, maybe a traffic summons, whatever, or the power went out. So FP&L gives you a note that says the power, the internet, whatever. Let me know what's going on, and I can help you not get that 20%. And they do get one letter grade off. So be careful, and I'll work with you. But again, talk with me. Make sure you know what's going on every week. I send you an announcement and what is due. It's always according to the syllabus. When in doubt, go back and look at your syllabus, okay? Again, what this tells you is just talk to me and try to get your assignments done, on time. And again, you can't, let me know. And I like paper. I like to write it down. Today, the phone, you can write in assignments when they're due. Whatever works for you, work with it, okay? Let me see. Any problems with your technology? You can't get in. The grade didn't push over into Canvas. Let me know. Sometimes I can find grades. Sometimes you need to put in a help ticket. You let me know. I'll tell you what you need to do. As I said, I'm here to help you. I don't do scheduled tutoring sessions. I make my life fit into yours when you are available. If we're going into the cardiac thing and you're not understanding congenital heart defects and maybe some blood flow or something or shunting, you need to little tutoring, we can do 10 minutes. We don't have to do an hour. Whatever you need, I can help you, and I'll work again with your schedule. The grading is you need a 78.0 on your KGA. KGA is a key graded assignment. That's your unit exams, quizzes, and your HESI. You need a 78.0. Once you get that, we'll add in, quote, what we call the homework, all the everything else. Be careful. Get your homework done and at least get the 80 on it because it can affect your grade quite a bit. I have had homework fails. I had one last quarter, not in Cutler Bay, but it was one last quarter and two the quarter before and other classes. And that's something you have control on. Again, if it's something that's holding you back with it, again, just talk to me. I think you're hearing this, right? Now, one thing we do is we turn homework grades on and off, it's called it. And what does that show you? Well, right now we only have those key graded assignments on exams, quizzes, and the HESI. Well, we don't have the HESI yet, but you're seeing what your average is, right? Now, on week 6, you're going to have assignments turned in, which have scores on them, etc. And you're going to see how it reflects on your grade. If you didn't turn it in, you're going to see your grade go down quite a bit. And then on week 8, we turn them off. Week 8 is your drop week. So we keep them on till then to let you know where you're heading. Some students, it is the homework that they're not doing it. And it's going to show you that when we turn it off, you'll see the differences, etc. So that's just to help you. Once they're turned off on week 8, they will not turn on until after the HESI and all the remediation's done, and that is your final grade, okay? That's what I just said there. Quizzes are done in the beginning of class. They are on last week's information. So next week, week 2, what is it going to be on? What I'm talking about tonight. How you study for that quiz. You've got a PowerPoint and you've got a Kahoots to study, okay? And then all those concepts, you're not getting it. You have a book that you go through and look at and refresh yourself, okay? Exams are in ExamSoft. When you come for your exam, make sure we come a little bit earlier. You have an ID, whether a license or your Fortis ID badge, and I'll be checking your area. Nothing on your head, no hat of any sort on your head, okay? Make sure that your ears, there's no earphones in there. If you have to wear things to block sound, I need to see them. And then, of course, looking for phones, the iPhone watches, etc. And I'll be checking around, your area to make sure you're safe. And the reason why we do this is we're trying to make sure that you're doing it correctly. It's easy to cheat, but you only cheating yourselves. Because when you get to the HESI, guess what? Cheating isn't going to help you. You've passed the course, but you won't pass your HESI. Rafaela, do you have a question?
Yes. Quick question. So it's ExamSoft, not Exemplify. I don't think we've ever taken
It's
any.
the same thing. Same thing.
Oh, okay.
Same thing. ExamSoft is Exemplify. Same
Oh,
thing. Yes. That's the big name, and that's the program that uploads into your
oh,
computer. Same thing.
okay. I thought they were different. Thank you.
No, you're very welcome. That's actually a great question. On exam days, I don't give grades out until we do this, what we call an item analysis. And what that means is me and the other pediatric professors get together on Saturday, usually about 1 o'clock in the afternoon, because we teach up till 10:30 on Friday night. So we can't do it before then. And we're looking at the questions. Are they fair? Were they written correctly? Or do we need to say that question can't be given because the way it's worded, it could be misconstrued as something else? And we look at that sort of stuff and we just throw it out. So just to let you know, I try to keep everything as fair as possible for you. Now, there's going to be times where all of a sudden I've seen students where the internet just shut off, the computer screen went black. All of a sudden you didn't have a charger and your computer shuts off. Make sure you have your chargers, but you know, it happens depending on life that occurs. If you're in one of those situations and you cannot continue an exam or quiz immediately, don't try to start again. Stop. All right? And what we'll do is we'll do it at another time. Send me a message. I can actually see every stroke you've done on your keyboard, on the exams and on the quizzes, and I can see all of a sudden it went out. I can see those sort of things. And then again, we're going to let you, I will schedule another time for you to get these things done. I've had hailstorms, I've had a car accident busting down telephone poles, all different things have happened where students had to stop. So again, don't worry. The exam is still there, and we will get you at another time convenient for you and get it done, okay? Now, a lot of times things happen and you can't take an exam. Make sure I know before the exam starts, and we can make other arrangements for you. There are times like Professor Hernandez likes to proctor exams. She's done that a lot. In fact, I oriented her to Fortis, so we're very good friends actually. If you have somebody who's going to be doing a proctoring on campus, they need to email me and we need to set up the time, etc., for you. It happens sometimes. Again, I need to know this before the exam. They're saying 72-hour notice, and that proctor has to email me because without me, they'll have no access code. They can't get into the computer, into the program, and they can't get to give you the exam. Okay. So none of that's a problem. I don't mind. But again, communication. I've already done all that. Missed exam. If you missed exam and didn't notify me, you will start with a minus 10% deduction. If you let me know all of a sudden, let's say you're running to the ER, your husband, your mother, your whoever, let me know as this is occurring and we can reset your exam. I can send you to other professors' exams. I can proctor you alone. Many things can be done without a 10% deduction. So again, tell me before. Once you missed an exam, you have 7 days. So today is Tuesday. You have to have it done before next Tuesday, if today was the exam, before class started. Okay? That's the way that works. So your homeworks. Again, your syllabus is exactly where everything is. It's all written out on your modules pages. We know the first day to the 7th day that, that it's late, it's minus 10%. After 1 week late, it is a 0, unless there's extenuating circumstances. And I've been told before that whatever was due before it was due, okay? I think you're hearing it over and over again. NCLEX questions, make sure you do the questions that the modules ask. I'm going to give you a little clue. Week 3 is the first set that is due, and it's on growth and development. It is not in the pediatric section in NCLEX. There's a separate one for growth and development, and I do look for that. Very important in pediatrics, because if they're not growing the way they should, developing the way they should, something's got to be done, okay? I don't want to see that little green square given to me as the homework, the NCLEX done. I want the 3-4 pages, whatever it is, so I can look at the sections, what you have done. If you send me in something that's not correct, you'll see me put a 0, but I'll put you the instructions in a message, okay? So that you can go and read it and figure it out. If you can't figure it out, let me know. We can meet on Zoom quickly and I can get it to you so that you can understand that, okay? You will get your full grade. I put that 0 there to alert you something was wrong, not to tell you you got a 0 or you've got deducted. make sure you get the best grade on NCLEX that you can, all right? That's a free ride. It's 5% of your grade in the end, okay? CJ Sims. CJ Sims can only be done when they're scheduled, okay? This is one thing that you can't do early. I've gone through them and looked at them. I actually really like them. I think it really starts to make you think of what to look for and outcomes, etc. I need a page where the top right corner says your name, and then it's going to give you a percentage of the overview, and then I can give you a grade for it. If there is a problem, again, I'll put a 0, and in the text box on the comments, I will tell you what I need, okay? Once you give it to me, you'll get the grade that you're supposed to get. At the end, there are 2 what we call case studies. It's the assignment and practice exams, and that's week 8 and week 10. Again, go through the modules. They can't be done early, all right? And I always leave them open a week later. Be careful. Some students think that if it was due today and they see it not till next week, they think it's due for another week. That is that minus 10%. I leave it open like that so it's still open and available for you. And it's one try only, okay? Let me see. Now, one of the things we have is what we call a pediatric assessment assignment. And I want you to think about a diagnosis, whether you had, your child had, your neighbor had, your sister had, something that interests you. It could be something as simple as asthma, or it could be a very complicated congenital condition to George or Pierre Robin, or I mean, there's all different stuff. What I want you to do, it's a 3-section thing. You write a paper, 250 words, like hardly anything, okay? Just describe what it is. The second thing is a longer, it's multiple pages, it's an assessment. The assessment must match the diagnosis that you're talking about. It's about asthma, I want to hear pulmonary, I want to hear about the wheezing and the retractions and the tachypnea, okay? And then the third thing of it is either a brochure, a PowerPoint, or just a picture board on some sort of teaching. I mean, in asthma, could be teaching you on how to use an inhaler, okay? I mean, it could be as simple as that. Teach me something. Again, make sure there's references on that PowerPoint and on the paper. And you know what I do for this for y'all? If you hand it in early, I will review it. I will give you comments, send it back, and you could increase your grade if you change the things I tell you to do. And I've had students send it back 3-4 times. So it is 6%. It is a big portion. I can help you if you send it in early. Don't expect on Sunday night when it's due for me to be doing this. So at least Friday, give me a little leeway. You can even start looking at that now because it's week 8 and there's a lot going on week 8, and MedSurg 2 gets pretty rough by that time, okay? Follow the rubric, do APA. If you have trouble with APA, there's something called Purdue OWL. And it's an online thing where you can even push in information and they can give you references made out correctly. I mean, it's a really good help. And again, if you need help, I can help you there too. So as I said, quizzes are at the beginning of the class. It's through the modules. If you have accommodations, if anybody has that, I need that information now. I need the copy of, the notice that tells me from Fortis that you have accommodations. I can increase your time on your quizzes. And of course, I'll make sure Dr. Brown has it for increased time for your exams, okay? So I need that ASAP because next week we're having our first quiz. And I want you to get the time that you do need. Again, any problems, technical issues, something goes on, stop. Send me a message immediately. I can reset things for you to do it another time, okay? And your HESI will be given at campus, and it will be on a week 11. I want you to know last quarter's HESI's grades were over 900. That was, my average. So if you do what I tell you, you will do great. And I've got some great cahoots for your HESI warm up to help you. I also do what I call a HESI Q&A, and I talk about topics and how to use them and apply them. And it helps not only for this HESI that you'll be taking, but it continues to make you think as you go into capstone, because capstone is thinking. It's not memorizing information. It's applying that information and being able to see, to think, and to know, did it work, okay? Remediation, you're not going to see a HESI score on your grade book until remediation is done. I can see them very easily. So those are usually due by Monday night, and then Tuesday, you're going to have all your grades posted for you. And, these review and questions are all about, we apply teaching. Also, we apply it to being a nurse. For instance, if you're late, you don't do an assignment and you didn't tell anybody, it's like not doing a treatment on a patient, right? And you didn't tell anybody about it. So you've hurt your patient. So this is the way you think about being timely, getting things done, open, good communication. That's what makes a good nurse, being able to communicate well. Any questions? So I think the key thing is talk to me, communicate with me before things are due, right? Javon, I don't see you anymore. You left me. Javon, hello? Anybody have his cell phone? Text him. Andrea, what's going on with your camera also? Does anybody have Javon's cell phone to text him? Tell him.
Yeah, I'm gonna WhatsApp.
Thank you, Andrea. Now you must be on camera. If not, now this is your first day with me, but if you're not and I see you continue, I will remove you and you'll lose attendance. Okay, that's what Dr. Brown has taught me to do. So that's what I will do. Okay, so we'll give him a moment of unclarity right now, but we're going to go on to our next PowerPoint. Any questions yet? All right, here we go. And we're going to go. Now, were you all able to open up your attachments on the announcement I sent? I sent a bunch of different.
I was not.
All right.
I tried to open the attachments and announcements and it said user not able to.
All right. I'm going to send it
as well.
All right. I'm going to be sending them to you in a Canvas message. You'll get them again. And my students from yesterday said that they were able to open the ones that I sent to them after class. So I'm going to resend all that to you, okay? So that you will have it. No, you're very welcome. Very important things that are in there. So pediatric nursing, we're talking peds and we're talking about, healthcare. Well, many of you, because where we live and Baptists likes their nurses to be bachelor prepared, right? And master's prepared. They encourage education. So I know many of you will be going on in whatever place that you decide to go. One of the things that you do for your BSN is you do a lot of papers, a lot of PowerPoints. And you have to decide on what are you going to be talking about. Now, I love peds, so I did all of my stuff on children. Now, my PhD dissertation from Barry University is on school-age children's attitudes and behaviors towards injections. why are children afraid of injections? Or that no pinche, no pinche, because I've heard that forever. And then there's some kids who don't care. So school age children are a great population to ask. And what I found out is these children just want to know what's going on and they want honesty with it. But what happens if nurses don't take that time? They will be afraid. They become adults who are afraid. Then they have needle phobias. They're not getting immunizations. They're not getting flu shots and COVID immunizations, et cetera, right? And then what happens? We have all these disease preventable things that you just get an immunization for. They're not getting them and they're coming back. So children become adults who now are needle phobic, who make their children needle phobic. And what happens? We have a population now who is not as safe as they could be through immunizations. So stop that needle phobia now, and it works better in the long run for everybody. So why did I just say that? Healthy people 20, and I had started with 2010, then it was 2020, now it's 2030. And the government looks at different things to look at. And it's a great place to look for topics for papers. Looking at all of these things can be part of it. I mean, nutrition is huge, and children have mental health issues. So all of these things are topics that are looked at to better the quality of healthcare for children, okay? One of the big things that we see is children today, they tend to be a little bit more overweight. And overweight children can become the adults or adolescents who end up getting these things like hypertension, diabetes because of overweight. And it's something that's looked at. I mean, today, if you look at children, they come home and they're really right towards whatever game they want to play, right? And they're just there and on the phones and on their whatever the new Nintendo or whatever Switch it's now, for hours. And the problem is they're not getting up, going out, they're not running. And then they're sitting there and munching and snacking and they're getting bigger, right? And it can create problems in the future. So it is something that's been addressed. You've seen these things about, go outside for an hour a day, go out and play. I mean, it's all because of this healthy people and promoting this stuff. And then, the first lady is like First Lady Obama was all about getting up, going out and play and eating right. And it changed a lot of the school lunch programs, right? I mean, there's other things. I mean, childhood injuries, the biggest one is motor vehicles. Whether they're in it, in a car seat, the wrong way, or they're ran over by cars. Now, working in the ER, I've seen several children, usually that toddler preschooler age. They're out in the driveway, and let's say the next door neighbor backs up and runs over the kid. It happens. It does happen. So the biggest injury is children. And then you become adolescents. And guess what? Now they're driving. So that is one of the big things. Vaping is a big thing, and violence. And here's some great pictures to show you. Guns, suffocation, swimming. We live in South Florida. I just got out of my swimming pool before class. I love my swimming pool. It's great for me. But I've got a 6-year-old grandson, and I've had that, swimming pool for quite a few years now. Well, by age 2, my grandson, Christian, was doing front flips into the pool, back flips into the pool without swimmies on, floaties, nothing. He learned how to swim quick. And the best part, he will not even go in the pool without asking because he knows better. Because they'll be immediately on punishment. We really have forced that because, of course, you worry about injury and your children and, of course, your grandchildren. I mean, stoves and burning, and, of course, they're always getting into medication. They love to chew their Flintstones vitamins. I mean, that's the biggest one they get into. Well, who are these children who have more issues than others? And those are those children who are born premature, whether it's very low birth weight or a low birth weight. They have all of these issues trying to grow, to even get to the point where they can, use a bottle to drink or nurse, and go home, and they have these lung issues and intestinal things. So really causes a lot of problems. Children in poverty, homeless, they don't have proper refrigeration. They don't have food. They don't have, air conditioning down here. I mean, it was a hot summer. Immigrants, I live in, Homestead, the immigrants, the Mexicans who come in. I would see a mother with a child, a Mexican mother with a child in the ER, and I work triage a lot. I would be scared. I knew that kid is going to be the sickest of the most of ones that I'd seen because they're afraid of being deported. They're afraid of, the money. I can't afford this. Many of them don't even go to the regular doctor because they don't have the money for the copay, right? Really something that needs to be thought about. How about children with cerebral palsy or children with respiratory issues? I mean, they're chronically needing something. And then do they have insurance? Do they know that they can get insurance? Do they have that copay to go to that doctor? Do they have a facility? Do they have a car to get to the doctor? All of these things are really a big deal. Now, infant mortality in the United States should be better than what it is, but we lag behind many, 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 many other countries. They say a neonate is 28 days and less. They're called a neonate. Once you hit 28 days, then they're called infants up to age 1. So you're going to hear those terms interchanged, a neonate and an infant. So we know this country has done a lot of stuff, but we need to do a lot more to protect our newborns and the pregnancy process, et cetera, et cetera. And you're going to see in your careers a lot of changes done. Now, the first year of life, remember, these children are making an immune system. They're at risk for so much in that first year. They make it up to that first year, the mortality does decrease quite a bit. When they get to the school age area, it's even lower. But then you get to be the adolescent, and now they're like, oh, we know everything. I can do what I want. They start having absolutely no filter. They're trying everything, injuries, homicide, and they're really sometimes very sad, as in it's all about body image, those adolescents. So homicide is huge, okay? So pediatric nursing, and one of the reasons why many nurses don't want to work it is because you're not just with a child, you have a family. You have a mother, a father, a grandmother, a grandfather, an aunt, an uncle, best friend, and you've got to take care of all of them. Because what is a family? It is the constant. That is what a child knows. They don't know anything else but that constant, what their family is, okay? So you are teaching the parents, the grandparents, whoever that is, and that is also teaching the child how to better take care of them. So one of the things is, what is a family? Well, there's so many definitions, aren't they? There is mothers, 2 fathers, 2 mothers, there's a grandmother and a daughter, there's step parents, there's adopted. A family is whatever they consider it to be. Okay? And sometimes there's a multi-family, grandma, grandpa, aunt, uncle, mother, father, and they all live in the same place. And whatever they say it is, that is what a family is. Now, pediatric nurses tend up to be the counselor. They tend to be there in between mom and dad and grandma, grandpa, aunts and uncles, and trying to keep that family together, especially in really critical times. I mean, what happens? You had a kid who's ran over by a car, brought into the ER, and now everybody's going crazy, right? Your goal is to make sure that those family members are taken care of along with the child that's in there from the trauma alert, right? We have to advocate for them. We have to help them, care for them, teach them, and how to help them prevent injury for those children. So, families is all, as what I just said, they're all different types, they're all different things we do on them. You know, one of the things about it's the beauty of living today, and me who came from a very narrowed cultural background, very small town USA in New York, and I moved to Miami, and now I've had all these cultures. You know, my children's father is Cuban, my husband today is Jamaican, and my friends are Dominican, and I could go on and on and on. And with that, I have to understand what their culture is, what do they believe in, and to be a part of it. I mean, I think it's very interesting, learning all of these things, their religious backgrounds, et cetera, et cetera. And we know also children go to school and they are influenced also. So, I mean, we are multicultural here for sure, for sure. Let me see. So, a frequent health problem of migrant children and adolescents in the United States is what? So, migrants are coming over from other countries. And one of the things that we do that other countries don't do is TB testing. Tuberculosis is rampant, and I have seen it quite a bit here at Nicholas Children. Children coming in, spitting up blood, coughing, night sweats, all of the typical symptoms. And it's something that, we treat. And when I see these symptoms, I put on a mask right away, right? Something that you have to remember those things. Now, cultures do things a little differently. Now, I am the gringa. I mean, total gringa. So I have the values that my mom and dad gave me, right? But now I'm in an environment where there's all different sort of people. And I'm taking care of these children and the families, right? So I need to understand things like, is there a problem with a male taking care of a female child? Is there a problem with foods, clothes, how you dress, how you look at them, how you touch them? All of those things are important in how to take care of any patient, but children and the parents, right? And the one thing that I've learned is if I don't know, I ask the parent. And I want you to know that parents are really excited and happy to explain things to me because I asked, which meant I cared, right? Now, one of the things that I've heard about is you can't go to bed with wet hair because you get sick. And if it rains, you go outside and you get wet, you're going to get sick, right? I have seen things like you must wear socks on the floor because you're going to get sick. And I've had to teach many patients that, your child has a fever. And one of the ways that you can get rid of fever, take the socks off and let them walk on the floor because it's cooler and it pulls the fever out. So making them understand in a manner that will help them. Some things happen with newborn infants that come into the hospital extremely ill. I worked in the cardiac intensive care unit for 10 years with Dr. Burke. Love the man, great surgeon. I built the unit when it just started here. And, you get these children in that are sick. One of the things that parents need, especially ones that, have a good spirituality, is they want their children baptized or whatever it is called in their religion to have, the priest and the rabbi and the minister, whoever, and to make sure that you give that parent the time that they need, which means you have to sometimes back up when a lot of things are going on and give them that opportunity. What about Jehovah's Witness and giving blood? Now, one of the hardest things is giving blood to a Jehovah's Witness child. Well, look at newborn ICU, look at a premature infant, and now every day you take a little bit of blood, looking at electrolytes and looking at this and that to be able to give, the proper medicines or to put up the hyper-al with the proper electrolytes, et cetera, et cetera. These children don't make their own blood yet. That doesn't happen until 3 or 6 months old. So what happens with blood cells? They die off, right? Now, all of a sudden, your hemoglobin hematocrit is 7 and 21. They're symptomatic. And when children get symptomatic with low hemoglobin hematocrit, they go apneic and they go bradycardic. So we asked the parents, can we give blood? And the parents, no. The reason I have found out, because I asked, is they feel the soul of somebody else is being delivered to their child through the blood. That's what I understood them tell me. So we go and we get a court order through risk management, and parents know it, and I'm going to give blood. Now, I worked night shift most of my career, 23 years of it. I love nights. So what I would tell these parents is go home, call me back at this time, and I would already have administered it. I don't bring the blood up. I don't have it in front of them. It's not sitting there on the desk to give. I don't want them to have any part of it because that, again, is putting it in their face, right? That's not nice. So I would do it that way. Or I've worked some day shifts where I had to give blood. I would tell the parent to step out of the room. I'd pull the curtains. I would do what I needed to do. I would put the blood started on the child, and I would cover everything with a blanket so they didn't even see a tubing with blood. And these parents were grateful that I did it that way. I did it safe, and I did it with respect for those parents. So that is some things that you consider as a nurse. You wouldn't think of that normally, but this is something that means a lot to those parents and the child as they grow up. Food can be different. You have vegetarians, don't eat pork, don't eat this, don't eat that. You've got some cultures that are into natural remedies. My husband gets sick. It's a garlic and lemon and ginger boiled up in this water, and he drinks it and he gets better. There's all different sort of those type of remedies that people have. And is there any problem with that, giving that? No, unless it's going to interfere with the medical care that you're delivering, right? So as I said, that pediatric nurse is there, they're the counselor, and they help and to teach and to give them information that they do need. So the leading cause of death among American boys ages 15 to 19, what do you think it is? They're getting
Firearm.
risky behaviors. Yeah,
Fireman outside.
absolutely. They're all of a sudden they're getting into those risky things, firearms. So genetics, going from being born up to being old and trying to look at those things in many different eyes. Now, we're going to go into some theorists and whatnot. We're going to repeat them again next week. It's something difficult to understand, but I'm going to give you enough information and explain it in a manner I hope that you'll get it, okay? And if you don't, stop me. So when we're talking about development, the one thing about children, think about this. A baby's born at 7 pounds. At 6 months, they should double their weight. So that should be, if they're born at 7 pounds, at 6 months, they are 14 pounds. At 1 year old, they should be 21 pounds, triple their birth weight. They go from not being able to lift their head to by 12 months, they should be attempting to take a step, or they already are. So it's interrelated, simultaneous, and ongoing. They are growing so quickly in that first year, and it's so much to look at. But again, if they're doing it going in the right direction, they're either doing the right thing. And if they're not, we can interfere and give them some intervention to catch them up there. Now, stage of development, there's all different words that we use about this, and I like the sequential trend. You lift your head before you turn over, you crawl before you creep before you walk. These are all the things that you'll see. And developmental pace is, are they hitting those milestones? Are they lifting their head? Are they turning over? Are they crawling? Are they walking? All of these things we'll be looking at. Now, I did send you it was a PDF just on vital signs on children. Now, adults, it's easy, 60 to 100 is their heart rate, right? Well, what about a brand new infant? What's their heart rate? 140 to 160 at rest. So why do you need to know that? Well, are they dehydrated? Is it too high? Do they have a fever? Is it too high? Is it too low? I'm going to give digoxin. What heart rate do I need to see? So every age children have different numbers, and it's something we need to understand. Heart rates go down as we get older. Blood pressures on a newborn infant, normal, 60 over 40. Adults, 120 over 80, right? And as we get older, the number gets higher and higher. So take a look at the chart. It's a reference. It's not an exacting science, but it's something to think about when you're asked a question about heart rate and what you need to do for it, okay? And it makes you think, is it elevated because there's a fever? What? We know newborns are very easy to get cold quickly. You know, at birth, what do? We put a hat on them, we put them underneath a warmer, right? Because they lose their heat very, very quickly. As they get older, then we don't need to do bundling of 3 blankets, et cetera, right? Infants at birth and the first, couple of months, they're going to sleep most of the time. But as they get older, they'll sleep less with less naps, et cetera. Now, you're going to hear me say nutrition, nutrition, nutrition. If you don't feed the body, it's not going to grow correctly. It's not going to have the normal height, the weight, and cognitively, they're not going to be where they should be. They're not going to be able to turn over and sit up and crawl and walk. They just, if you don't feed the brain the food it needs, okay? Nutrition, nutrition, nutrition. And we know all infants, children, they're all different. You have a kid and they're like the easiest kid, so you have another one. Oh my goodness, that was a difficult one. But remember, everybody's different, and that's who we are. So I talked about human behavior and describing it. These are the ones that we look at. Now, Erickson and Piaget are always on your HESI, always on your NCLEX. Just to give you a heads up, it's something to look at. Your first exam has, I believe 6 questions on theorists. So it's something that you're going to need to understand, all right? So Freud, anything about sex, right? Oral, infants. How does an infant soothe themselves? Oral. How do they explore the world? Through their mouth. Everything's oral, right? A pacifier, a non-nutritive sucker, pacifier. Then they get to be toddlers, and it's all about potty training, anal. Phallic goes into those preschoolers. They're starting to explore and understand there's differences, boys and girls. Latency is all about best friends and same-sex peers. That's what they like. And then when they get 12, that's your adolescence, and now they're getting into exploring their sexuality, their genital. Now, Erickson, there's all these different words. And, again, I'm going to go over them again next week, but let me try to explain it. And then hopefully by next week, you'll understand more. So as your infant, it's trust versus mistrust. And what Erickson says is if a baby cries and somebody goes, picks them up and tends to their needs, that baby trusts and has trust and is a happier, healthier baby because they trust, right? Now, what if they are in a situation where they don't get picked right away and they're there and they're hungry and they're wet and they need to burp and whatever? That is mistrust. So they didn't get the needs that they needed. Now, toddlers, autonomy versus shame and doubt. Well, what does autonomy mean? Autonomous. They want to be autonomous. That means they want to go out and explore and look at everything. They're into everything, and you know that. I call them, they're like a child, the blender with the lid off. Turn it on, and they're like everywhere. I mean, toddlers are like that. That's the being the autonomy. The shame and doubt is us, the adults, telling them, oops, be careful, don't do this. Here, watch that. Oh, don't here, and put this on, and stopping them from trying to do things that many times you need to let them try. That's the shame and doubt. Initiative versus guilt. Well, those preschoolers want to help. They want to do. They want to, do things and be a part of the family. Well, the guilt is when they don't do it right, because we're going to tell them, and it's just part of what we do. Now, school age, and probably one of the most tested of all questions, is all about school age industry versus inferiority. Like, why do they use the word industry? I'm not sure. Well, school age children love to do things well and get praise for it. Whether it's running the fastest, maybe it's the best at math, the best at writing, spelling. They are great at it. That is a task they do well. Could be baking a cake, playing a piano, doing ballet, soccer, whatever. Industry, what do I do well? And inferiority is everything they can't. They feel inferior because they can't do everything well. Well, we know that's normal, but school-age children feel inferior. And then your adolescence. Identity versus role confusion. Well, identity is, what is an adolescent? They're becoming adults, and they're going to become something. They get into sexuality. Are they a girl like a girl, or do they like boys? What am I going to be when I grow up? Am I going to play an instrument in the band? Am I going to play sports? Identity. Who am I? I don't know yet. And then the role confusion, again, is part of figuring out where do they fit in with everyone else and making it something that they do like. Okay, so that's Erickson. Now, Piaget, the only one I'm going to talk about is sensorimotor. And then the rest, I have a chart and pictures for you next week. It'll make more sense for you. Now, Piaget's all about thinking, cognitive awareness. Sensorimotor, an infant, when they're born, they have what we call a reflex grasp, where mommy takes the finger, puts it in, and the baby grabs a hold of the finger. And the mom goes, oh, look, they gave me a hug. Well, it's a reflex. And I'm not going to tell mom it was a reflex. Well, that reflex now becomes voluntary, and they grasp stuff. So sensorimotor, they grasp that rattle, and all of a sudden they move it, and it makes a noise, and it shakes. And the next time they get it, they shake it more because now they know. And they find, let's say they find their finger in their mouth and they start sucking on it. And we know that's their self-soother. So when they're stressed, what do? They take their finger, put it in their mouth, and they self-soothe. Sensorimotor is the basis of children. Everything is explored through the mouth, moving it around. What does it feel like, taste like, sound like? This is all children and the exploration. So language development, what does it start as? Well, cognitively, children, well, we know that they cry when they want something. What's the first thing children do? Babies do. They cry because we whack their butt, right? But which helps with their lungs expanding. But they cry first, but then they learn they're going to coo. They make these little noises, and how the parents go, oh, look, they're talking to me. So they start with that and they build upon it. They learn how to communicate. And then our job is to stimulate them, to teach them other ways too. Now, Kohlberg, all I'm going to say about this is all about moral development, right and wrong. And the other part of that is the consequence for each. I'm going to do the right thing because I'm going to be praised. That's the younger child. As they get older, they're going to say, well, that's a wrong thing to do, but all right, I know I'm going to have this consequence, but I need to do it. I'm going to do it anyway. So as they get older, they work with right and wrong. When they're younger, they just want to do right. They don't want to be wrong. They don't want to be punished. And that's Kohlberg, right and wrong consequence. Now, play. What do kids do 24 hours a day when they're awake? They play with something, somehow, somewhere. And there's different sort of names for this play. We play together, sense pleasures, sand, mud, water, skill, building a block by themselves, or they're pretending. And of course, there's always board games. So what do toys do? Well, it helps with that sensory motor development, right? All different toys, all different touch, all what they feel like. I mean, that little baby getting into that purple paint really had a great time, right? And it's all sticky and they just feel great. They don't realize that now it's a big mess to clean up, but it was that sense, that pleasure that they receive from it, and they're happy from it. All of this play helps them do things. They'll take one block and put two blocks, and all of a sudden they realize it's another block, or they learn how to put something underneath and make it and be creative with it. It really develops their mind. And it does help these children grow and to think. Now, you need to know the types of play. Very simply, onlooker, they're looking at somebody to play. Solitary, playing alone. Toddlers are a parallel play. I'm playing here with a truck. This one's over here playing with their own truck, and they're not playing together. They're next to each other playing. Associative play is now they're playing with the same cars and same trucks, but there's no goal for what they've done. It's not like going to the beach, working together and making a sandcastle, or playing a board game and then somebody wins. There is no result, no outcome. Associative, two or more children playing together, but no goal. Cooperative play is when there's a goal that the sandcastles build, or they're playing checkers and it's a board game and somebody wins. So cooperative, they win. Associative, they play together. Parallel, they're next to each other and not solitary alone, or I'm just looking with onlooker. Play is important because it helps with their development. Putting toys farther away that they can reach helps them use their muscles and try to move and roll and to get to it. If they want something, they're going to find it. One of the things about that is something called object permanence. And object permanence is they saw that let's say stuffed toy, let's say a little teddy bear, and you hid it somewhere. That child, because they've already seen it, know it's going to be there and they go looking for it. That's when they roll and they start looking. That child who's like 1 year old, mom picks up the toys, puts it in the toy box. They go to bed. That child knows to wake up the next morning. He knows the toy box, that toy is going to be there. That is object permanence, okay? Now assessing, looking at kids, there are all different things to think about. If you have a child who has some sort of disabilities, there's going to be some different assessment ways that we do things. Some children are older, they don't speak yet, they're nonverbal, they'll never talk, and then you've got young kids that are just on their normal and talk and don't stop talking, some of them, they're so cute. Children are born with many different things, many different abnormalities, from a cleft lip, cleft feet, etc. Or it could be a syndrome. You think a syndrome, many of you think immediately Down syndrome, right? But there's so many more of them. Or it could be caused by some sort of drug, etc. A lot of times there are genetics that can cause problems with children. One of the things that we have that you'll hear about later on, I think 8 or 9, is something called Duchenne's muscular dystrophy. And it comes from mom. And what we're going to say with that is genetics. And it's very important that if we find that that parent has a child with this syndrome, the chances of another one are great. So it would behoove them to go through genetics and to help them and to educate them and let them understand where these things came from. It could be things came from chemicals, infectious, could be physical, or it could be something metabolic. That's why we do those little round circles at birth, looking for PKU, making sure they're going to be eating correctly. And it could be chromosomes. I mean, Downs is 18, right? 21. But 22, that's the George syndrome. So there's all different according to chromosomes, okay? And us, what do we need to do when we have these children? Sometimes these children, let's say they have cleft lip, bilateral cleft lip palate. And these children don't really have a mouth and they have their gums hanging there. And some parents are afraid to touch their child because it doesn't look like a newborn baby to them. They're like, what is this, right? What do I always do for those parents? I make them sit down. I wrap up that infant if I can and able to, pick it up, and I put them in their arms. And we'll talk about, oh, look at all that hair. Oh, they've got big eyes. And just doing something like that helps with that attachment for that child. So I'm not going to go over this question as to show it to you. What I'm going to show you is there are different sort of things, and we're going to be going into that with Piaget next week. But it just tells you that there's ways of thinking, cognitive awareness, like that object permanence. We know that that toy is still there, even though we can't see it. And it's all about figuring things out, putting things in order, etc. So you'll be seeing those things again next week also. And then assessing a child. Well, one thing about pediatrics, 18 years old, cognitively and aware child can sign their own consents. Now, not only can they sign their own consent, they also have the ability to tell you they don't want their parents to know anything. You have to ask permission from the child if you can speak to the parents. So be very careful with HIPAA with children, because there are some things that you need to be concerned about. Now, when you get a child coming into the ER, urgent care, doctor's office, one of the things is communicating with the mother, the family, whoever it is, and listening and getting the information you need. And again, a lot of it is understanding cultural awareness. Some of them don't want you touching them or looking in their eyes directly. There are cultures like that. Or it's you don't talk to mom, you talk to dad. Or maybe you need to speak to the grandmother instead. So understanding cultures, who to speak to. And then, of course, being there, being empathetic, letting them speak for what you need. Another thing is, don't ask another family member to be your interpreter, because that family member could change the tone of what that person's trying to tell you. So they tell you to get an interpreter, okay? Children, number one, you walk into a child's room, don't think you can go there and touch them right away. It's not going to happen. First of all, you need to get down on their level, as in sit, so that you're not towering over them. In the ER, they'd be on a stretcher. I'd have a chair and I'd sit below them. And then I would start with, oh, wow, your sneakers light up. They're really cool. Or where did you get those big blue eyes from? Or maybe they're wearing a Spider-Man shirt. I said, is Spider-Man your superhero? So now I've got their attention. And then I'm going to make play. And we're going to play, okay, I bet you don't know where your nose is. And they're going to start with showing me stuff. Now, I have to do an assessment, right? So I've got to touch this child. Don't think it's head to toe. It's not happening in children. You get to do what you can do when they give you that opportunity, okay? So using play, getting on their level, being on their developmental level is the most important thing, and playing with them, letting them touch the equipment, let them push buttons on machines. This helps a child work with you a lot better, okay? As I said, the history is probably from the parents. Make sure they don't go a long dissertation from birth to 8 years old, everything that's gone on, because you need to know why now. Why are you here? Important questions on an admission would include things like allergies, any medications today, and very important is immunizations. Don't assume every child is up to date on immunizations. Some of them aren't. And if you have a child with an upper respiratory, it could be something more serious than just upper respiratory infection, okay? And that would mean, where do you place these children on your nursing unit? And that's me wearing a mask protecting myself or another person. So all of these questions are really important. Talking to adolescents is a little bit more difficult. Many of them will not talk in front of their parents, especially if you're talking about sexual history. You can ask parents to leave and then talk to this child alone. And you don't have to tell the parents what they've said unless it's something that could harm themselves or others, okay? So getting the history as much as you can, and then figuring out who is the head of this household, and making sure that you've got a good open communication. Many times when I'm talking to kids, they're not talking much. I'll start talking about their school, what's their favorite class, things of that can really help just with keeping them calm. Um, Another thing is those unusual habits. Now, a child might have a certain blanket, a toy, a certain pacifier. That's the only thing that settles them down, right? What if the parent has to run to the cafeteria and the kid's in there crying because it fell on the floor, whatever that is? Because you already asked what those things are, you can give it to the kid and calm them down, right? And then that kid is getting more and more trust with you. Dietary is important. Why do you think every visit on a pediatric child, they do a height and a weight? Every kid, every visit. We want to make sure they're being fed properly, right? That's number one. Are they getting proper nutrition? And then as we go further in the course, it could be something metabolic or something endocrine. They're not getting enough, whatever. So height and weight on a child is so, so important. And we can make changes according to that. As I said, head to toe is not going to happen. It happens for adults, not children. If you have an infant in the mother's arms asleep, you're going to listen to their breath sounds and their heart sounds, because once they're awake, they're going to be making noise, they're going to be moving, and you're not going to get a great assessment, are you? So you might have to do a little bit now, a little bit later, but don't think it's a head to toe. It's not going to happen. Again, making sure you've got that child prepared, you're on their level, you've had some fun, you're playing some games, and then now you're going to do all the things you need, and you're going to make it fun for that child. When you're talking to kids and they've got to do a procedure, let them know exactly what's going on, to an extent. Let them know if it might hurt a little bit. Very important, because you're going to lose trust on these kids if you're not open and honest with them, okay? And always make sure everything you do and say is on a developmentally appropriate for this child, that they can understand, okay? And explaining to them why you're doing what you're doing in a manner that they understand. We do all different stuffs. I mean, a radial pulse, Not till about 2 years old on children. You would do an apical pulse. You have blood pressure cuffs from size 00 to extra large adults. So it could be from something to go on a finger like this, or on my arm, the extra large cuff, right? So making sure that we use, when we're grabbing equipment, getting the one that's appropriate for that age child. Sometimes I take 2 different size cuffs for a blood pressure because you don't know. Knowing about all of the different things, looking at them, what's normal. I mean, children got big round bellies. Adults, well, not everybody has a big round belly, but they're different. Everything looks different. One of the things that we do at birth, and you're taught in OB, is you check to see if there's an anus because you do a rectal temperature. And it's not to check the temperature. You know what it is? There are infants born without an anus. So you're making sure that they do have it. Looking at all the sorts of neurological, checking their reflexes. I mean, I had kids doing my knees and everything, looking at and making it a game. And we get it done so much quicker by that game. Newborn infants, newborn ICU, every single shift, you're going to do a head circumference and an abdominal circumference. And sometimes you'll also do the chest, looking for things. I mean, it could be hydrocephalus, it could be feeding intolerances, constipation, it could be so many different things, looking at those numbers. You think getting a height on this little girl here is not a big deal. I'm telling you, that little piece of wood that comes down, they think it's going to whack them and hurt them. So what I do is make it a game. Number one, I let them touch it. I put me there first. I put it there. I say, oh, look at my number. I have a number 7. What's your number going to be? And then have them hold it. I'm like, okay, what's your number? Now, I have taken a very scary situation and now I've made it fun, haven't I? Again, blood pressure cuffs. I like using it on the lower leg, especially that toddler preschooler. I think they tolerate it better. I mean, put it on their brachial artery. I'm sorry, it hurts me. I'm sure it hurts those kids too. So if you put it on their lower leg, you can get it done a lot easier, a lot less pain. Now, pain, children. My biggest probably pet peeve working with them is pain and children. And we know children still are in pain because many nurses are afraid to medicate them. They give less than adequate levels, they wait too long, they don't give things in between. You need to do some distraction methods. I mean, distraction of a child. Let's say the kid's in pain and you give them something for medicine, and then give them some stickers to play with, or a coloring book, or turn the TV on. So I've done something on their developmental level to distract them from thinking about how much they're paying in. And distraction really helps with children. Now, there are different ways to report pain. Well, adults, it's 0's no pain, 10's the worst pain in the world. What number describes you? Well, that's called numeric. The other 2 ones that we use in pediatrics is faces and Wongs, okay? And there's something called black, and we're going to go into that. Now, numeric is children 8 years and older. Now, it doesn't mean kids younger than that cannot use it. I've used it for younger children, but the book says 8 years old, okay? Now, the last one here, FLAC. This is used for nonverbal children and children's 3 and less, so under 3 years old. At 3 years old, they become faces, okay? What is FLAC? Well, the initials. F is the face. What does it look like? Are they grimacing or are they smiling, right? Then you look at L, their legs. Are they like sitting there hardly able to move, or are they legs moving because they're in so much pain? Their activity, as I said, are they laying there or are they active and running around and then crying? And if they're consolable, I mean, a lot of these kids are in so much pain, you cannot console them. So that's flack. Now, faces is this right here. This is the scale. It looks like numeric, but there's faces. And children will point to where they hurt, okay? All types of pain from chronic, rheumatoid arthritis. Children have it and it's a chronic pain. Recurrent pain, sickle cell, persistent could be, broken leg. There's all different ways to describe pain. We know that pain that lasts for a long period of time, they say more than 3 months, really affects their entire life. If you were always in pain, and aren't able to do things that you want to, especially a kid, the other kids are going to tease you because you can't, right? It's really going to take an emotional dwell on these children, okay? There's all sorts of checklists and things you can use, especially for those non-communicating. Every hospital is different, see what's there. And, they are actually really good, these checklists. And usually they're very easy to fill out also, because they're saying now they want a pain level on every child on every shift as part of, the Joint Commission accreditation. And then cultural differences. I'm going to use this as daddy brings in his son for a broken arm, and the doctor orders a shot of morphine because they have to manipulate the bone and put a cast on. And daddy's like, no, he don't need that. He's fine. Suck it up, son. It's going to be all right. And you're like, it's going to hurt. But there are some cultures that think the boy, the man, should just not ask for something for pain, that, they can deal with it. And, this is something that I've worked with and tried to explain that one little injection, they're manipulating bones. It's going to hurt. You don't want your son to hurt. There are also parents that are like, well, they're going to become addicted on one injection. I'm like, no, not on one injection. As I said with pain, there's ways to make it less. I said it, a little bit earlier, and it's by distraction. Now, this woman here is doing what we call kangaroo care. I have seen little premature infants intubated in their warmers or on, an isolate, and they're just moving and they're fussy and, their heart rates are up and down. They're burning calories. They're miserable. Mommy comes, I take and put them on skin to skin, and you will see this heart rate go down. You'll see respiratory rate go down, and the baby will go to sleep. It is such a great thing. Using pacifiers, self-soothing, right? Everything in the mouth, self-soothing. That helps. All sorts of distraction for older children. As I said, games, music, iPads, whatever. Use whatever tools you have. It does help. We think pain is just the narcotics. It's just the morphine. Well, remember, Tylenol and Motrin on kids work really good, especially kids who've never had it. Give them a dose of Tylenol and it works really well. Opioids, morphine is an old drug. It's been around forever. We know the doses. We know how much can be given. And in some cases, they need to be given. And that patient-controlled analgesia, or the PCA pump, we use that with their teenagers, the older children, going through a lot of, let's say a lot of abdominal surgery or cardiac surgery. We do give it that little thing to push, and it does help them feel like in control. We do try this atraumatic painless or a decreased pain for children. We don't do that with adults. You need an IV, you're an adult, they stick it in, right? Big gauge, stick it right in. But with children, we are going to be using some sort of numbing something. Now, this girl has EMLA with a, tegaderm on top, this clear thing, right? That little gob of white stuff is a numbing cream. She's smiling because she knows she's getting a lab drawn, but she knows she's going to feel the touch, but she's not going to hurt because that's numbing it. So that's a difference in a child that's screaming, yelling, or a child that's like, okay, go ahead, I'm ready. It does make a difference. Pain can be from anywhere. I mean, here's all your examples: immunizations, post-op, burn, headaches, braces, everything's there. So, which of the following is an important factor for consideration in understanding the pain experience in children? What do you think? They're not going to admit being in pain. Why? They don't want a shot, or they don't want the liquid. Don't taste good, right? A lot of children don't like to take their medicine, so they're not gonna say they're in pain, but they're sitting there and they're not moving, are they? So that is your chapters for today. Any questions? I haven't put you to sleep yet? Not yet? All right. Has everybody played a Kahoots before? Go to Kahoot.it on your phone. When you get there, you're going to add in the number here, 226-6202, and you're going to sign in your name. Or you can take what you just did and take a picture of it for your camera and go directly there. That was good. I just learned how to do that. Taking a UPC and putting it on your camera. I didn't know how to do that, Miguel. I didn't know how.
Everything is much easier now.
Oh my goodness. Yes. But it's difficult when you didn't grow up with it. So I've had to learn a lot. Actually,
Well, look
I
at
do
the
pretty
study.
good.
Look at how people study now. Now we just Google everything. Before you had to go to the library and look for different kind of books to get a different kind of information.
Absolutely. I think about that all the time. It's like, oh boy. All right, listen, I don't go back. I don't look at your scores. What I want you to do is use this as a test for yourselves. This is to say, these are the concepts I need to look at, okay? So just know that. I'm not here to say, oh, you didn't get, you got 10 wrong. I don't look at that, okay? I believe there's 34 questions today. From a worldwide perspective, infant mortality in the United States, what? I wish the United States was further ahead in all of these things. I think Switzerland and Norway are really high. They got a lower one, but we're one of the highest in many other countries. But we're catching up slowly. The leading cause of death from unintentional injuries in children is what? What did I say? Unintentional. I mean, we don't want to hurt kids. I mean, that's child abuse. Motor vehicles. As I said, whether they're in it, run over it, or they're driving it as their adolescents. That's the one thing, it's a constant. Cars are dangerous. Which statement is most descriptive of pediatric family-centered care? It's why many nurses don't become pediatric nurses. I want you to know that I was always the nurse they gave that difficult parent to. Oh, Betty's here tonight. Give it to her. Okay. It recognizes that the family is the constant in a child's life. That's all they know. That's their family. As they get older, they understand more, but not younger children. The major cause of death for children older than 1 year is And that's your unintentional injuries. It's things that happen that you didn't plan for. It happens. I mean, you talk about a toddler. I've seen them crawl up the fronts of dressers, get to the TV, knock over and fall on their heads. I mean, I've seen some crazy things of unintentional injuries, especially that toddler. I call them my dive bomb kids because they're always somewhere. The nurse caring for the child in pain understands that distraction as I said, don't just give pain medicine, adult or a child. Also do something to distract them, turn on the TV, put on music. But remember, children must be developmentally appropriate. If it's over their heads, it ain't going to work, okay? So make sure it's something that the child understands. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? They're playing together. There's no goal. And that's called associative. Solitary is alone, parallel, they're next to each other, not playing with each other's toys. Associative, two or more playing with each other, all the same toys, but there's no goal. There's no sandcastle. There's no winning a game. Cooperative, they won the game, okay? Which statement best describes the process of critical thinking? You know, you're taught when you first start nursing school that you learn how to critically think. I mean, how many of you are thinking about what's for dinner? Okay, what do I have in the house? I got to go to the grocery store. You go to the grocery store, get whatever you need, come home and you make it. It's because you have made a plan, right? You have a goal. You know, everything is there. And same thing with nursing. Look what you need, and then you go ahead and get it. And then you look at, is that what I wanted to happen? It's your goal. What is probably the single most important influence on growth at all stages of development? Nutrition, nutrition, nutrition. A child is not going to grow and develop and be cognitively aware and do all your gross and fine motor things you're supposed to do if you don't feed the fuel. Nutrition, nutrition. Frequent developmental assessments are important for which reason? You know, developmental assessments, making sure they're lifting their head, they're turning over, they're grasping, are they fine grasping, etc. All of these things are things we as medical professionals, whether we're looking at an infant or older children, are they doing what they're supposed to do? And if they're not, we can catch them up. You know what's the greatest thing about children is they're resilient, and they will catch up and be where they need to be with early intervention, speech therapy, occupational therapy, physical therapy. Now, you all have such opportunity going over to Patches. Great place to see this in action. And by the middle of this quarter, you're going to tell me all about what you have seen there. Which function of play is a major component of play at all ages? What is that thing about play that is the basis from newborn up? sensorimotor activity, right? In the mouth, it's touching it, feeling it, what is it, moving it around and exploring the world all in the mouth. 3 children playing a board game would be an example of what type of play? And that's cooperative. Very good. Associative, there's no goal. That's not a board game. Cooperative play, there's a goal, there's a winner. The head to tail direction of growth is referred to as what? Well, let's just look at the word head, cephalic, right? So we know it has to be cephalocaudal. So it starts with moving the head first, head control, and caudal would be now walking by the end of a year, cephalocaudal. What is the single most important factor to consider when communicating with children? Get on their level. Very good. Absolutely. You need, if you're going to do anything, you can't talk over a kid's head. Sit there and talk to them that they understand, and then you can play with them and have some fun. What 2-year-old child pain assessment tool should the nurse use? So we have faces, we have numeric, and we have FLAC. Those are the 3 that you're going to be seeing. I mean, there's many more of them, depending on your hospital, whatever they use. But those 3, I think, really describe pain tools. So at 2 years old, it's still FLAC. Faces does not turn over to preschool, age 3. Okay? FLAC is your young children or your nonverbal. It could be an 18-year-old cerebral palsy child who doesn't talk, nonverbal. It could be FLAC for that child. Okay? Faces, that starts at 3, at preschool. At 6 months, an infant's birth weight should be what? So if they're 7 pounds at birth, at 6 months, what should happen? It should double. Very good. You listened. The first expected fine motor developmental milestones for an infant begins with. Now, fine is F, which is fingers. Okay? Then you're going to have gross motor, and that's get up and go, 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 like Paw Patrol. That's movement. Okay? So there's fine motor and gross motor. The first fine motor is hugging that mother's finger, giving the mom a hug when they squeeze the hand. It's a reflex. Then it goes to voluntary, grabbing that rattle. Then it goes into what we call a pincer grist, but more of a crude. You take them, put Cheerios on their high chair, and they sort of smoosh it in, right? And then all of a sudden it's fine, neat pincer grasp. Then they put objects in the container, and then by 1 year, block of 2. That's all fine fingers control development. Okay, you'll see that again. An 8-month-old infant should be expected to perform which fine motor skills? Well, I just told you the evolution of them. So which one do you think? So we can get that rattle and we're going to have that crude pincer. It's not probably at about 10 months that they're more fine. And then it's 11 months, it's the putting the blocks in a container. And 1 year, it's for blocks doing a pile of 2. The natural physical developmental sequence that most children go through is, and this is gross motor. It's another word for physical, gross motor development sequence. You'll see it X'd either way. What's the first thing a child does? They lift their head first. Very good. And then it goes to walking or attempting walking by 1 year. Which behavior indicates that an infant has developed object permanence? What is an object permanence? Even though it's hidden, they know it's there because they've seen it. Like the 1-year-old knows the next morning, go to the toy box, he's going to find his toy that he wants, right? Even though it's not in sight, they know it's there because they've seen it once already. And they don't forget. In general, an infant should triple their birth weight at what months of age? 7 months at birth. When do they triple it? So 7 pounds. Then it becomes 14 pounds at 6 months. And then we triple it at 1 year. Very good. Perform a head-to-toe assessment on a toddler. Most important to consider before beginning the examination. Again, remember, before you do anything to a toddler, especially your toddler, ages 1 to 3, make sure you're on their level. Again, get down below them, and whatever you're doing, make sure that you are speaking to them in terms that they understand. According to Piaget, toddlers are in a blank developmental stage. Now, you can rule 2 out here. 2 of these are Erickson. Trust versus mistrust, autonomy versus shame and doubt. So there's 2 left. What are toddlers? Those are the young 1 to 3-year-olds. And it's sensorimotor. Now, formal operations are the adolescents. They can figure out how to verbalize and get their way out of a paper bag and get what they want. They're going to do anything they need to say or do in order to get what they need. And when mommy said, no, you can't, they're going to figure out a way to get it. That's formal operations, really thinking. Remember, the young kids are all about the mouth and movement and that sensorimotor. Which intervention helps a hospitalized toddler feel a sense of control? I think toddlers are the hardest ones to be able to work with because they really don't understand what's going on. And one of the things is follow their own routine. Bedtime, nap time, if at all possible, try to maintain the same foods, and, of course, they have their own teddy bear or what there, but it is the routine, which is the most important. All children reach developmental milestones at the same age. Absolutely not. I mean, I had children and my grandson, none of them walked at 12 months. They all ran at 15. Just because they don't meet it at that time, As long as they're moving forward, they're doing good. And you're going to hear this question a lot. Well, my baby boy, he was doing this by then, and my girl's not doing that. Does that mean she's delayed? And the answer is no. All children, as long as they're moving in the right direction, it's okay. And you expect differences. Immunizations for a 4-month-old infant. Which action should the nurse take to provide A, traumatic care for this infant? So they're getting a shot in their leg, right? Probably more than one. And it's using a pacifier. There is a research study came out by Harvard neuropathophysiologists, I believe it was, and it talked about using a pacifier with sugar water on it versus morphine, and they found no difference in the pain relief. My grandson had a circumcision at 1 month old because it was so tight we had to. He just did it on a pacifier with sugar water. He cried a little bit, but not much. And it's because he self-soothed, right? Everything in the mouth, self-soothed. Which of the following immunizations can be administered to a newborn? It is the first one we give, usually at the hospital before they go home. And you're going to ask me, do you need to know what all of these immunizations are? There's 2 pages in your textbook. No. Hepatitis B is your first. You need to know that. If a mother has hepatitis, they'll give it within 12 hours of delivery. That's something you need to know. And then as we go along with immunizations, I'll let you know which ones that you need to know. I mean, we know at 2, 4, 6 months, they get a lot. And then about 15 months, 12 months. And as we go along, we'll be discussing those sort of things. The normal heart rate for an infant is And as I said, you need to know the heart rate for many different reasons. You need to assess them. And it is 140 to 160 at rest, absolutely normal. What is the preferred site to give an injection to an infant? You learned that in pharmacology. And if you look at what that professional's doing and how they're giving that injection there, I would tell you never do it like that. That can only lead to some problems and injuries. And it is the vastus lataris, and you would always have extra help. I developed a program for Nicholas children called Huggies, H period, U period, G period, etc. Help us give great injections efficiently and safely. And what I proposed is parents to hold their child for injections. There's less pain, fear, and stress because they're held by the mother before, during, and after. And these kids really didn't cry that much because they're already in mommy's arms. So Huggies is still a program that goes on there. And not only is parent going to hold, I'm going to have another nurse help. Because I've seen big scratches from needles. These children move or their hand hits it. And, you're in charge of keeping that child safe. The death of an infant under 1 year old with no known cause is called what? And it's because they're sleeping like this infant right here. You do not have a child sleeping on their abdomen anymore or on their side. It is called SIDS. Sudden infant death. The Vietnamese mother of a child avoids eye contact with a nurse. Considering cultural differences, why? Why isn't she looking at you? And this is what I'm saying, to understand culture. I mean, I would ask this mother, why don't you look at me? And it's actually respect. This is just respect that she's giving you. A mother from Mexico is hospitalized for a serious injury, and the father says the child is being punished by God. Why is he saying that? And that's a common belief from this culture. So again, understanding it, or you'd be like, why is he saying something like that, right? Which term refers to times in an individual life where he or she is more susceptible to positive or negative influences? Again, this is another one of those terms. And it's called a sensitive period. Very good. What is characteristic of the pre-operational stage of cognitive development? You know, thinking about being aware, and this is ages 2 to 7. And again, we're going to go over it again next week. I like to hit you with these questions this week just to have you thinking about it as we go on and as you get prepared for next week's lecture. Now, thinking is concrete. What does that mean? Children have to see it to understand it. They can't figure it out yet. So if they know that if you don't close the jar and you turn it over, it's going to spill. If their lid's on tightly, they know it's not going to spill. I mean, many different examples, but it's they have to see it to understand it, okay? They can't figure it out for themselves yet. And last question. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? And again, this is all about good and bad and a consequence for them. Very good. Let's see who won today. Number 3, Karen. Good job, Karen. Number 2, Dion. Good job, Dion. Number 1, Sheila. Good job, Sheila. And number 4, Nia and Javon. Good job, guys. So this is my end of my class today. Anybody have any questions? Anything they need? Or is everybody okay?